Okay, Assalamu alaikum everyone. I'm AbdulRahman Farahat. I'm a second year medical student, and today I'll be speaking about the anterior abdominal wall lecture. It's an anatomy lecture that you guys took 2 weeks ago, I think, at the beginning of the vlog. So today we'll be speaking about it. This lecture is recorded, however, you could still contact me anytime you want, please do. Okay, so let me just get my pen. Okay, let's start. So the stuff we'll be speaking about today will be the surface anatomy of the anterior abdominal wall and the vascular supply and innervation. And then we'll take a look at the arrangement of the anterior abdominal wall where things start getting a little better. And finally, the clinical conditions. Personally, for me, these two are like the dry part of the lecture. And so I'll be going through them a little quickly because they're mainly dependent on memorization and there's not much I could say about. However, the other two, there's some concepts I need to focus on, and you could probably get asked about. Okay, so let's start with the surface anatomy of the anterior abdomen. First of all, when you think of the abdomen, you'll have to know its margins or its borders. So when I say abdomen, the thing that comes to mind would be the area or the region that would lie between the lower thoracic cage or from the diaphragm all the way to the the pelvic inlet. So this would be the pelvic inlet. This is the pelvis. You're looking at it from the top. And this hole or ring-like structure right here would be the pelvic inlet. So the abdomen would lie from here all the way up to the lower thoracic cage. Okay, so how are structures organized anteriorly when you're first looking at it? So let's start off with the umbilicus. So everybody knows there's an umbilicus right here, and there's a line going just in the middle of the body, a median line in the middle of the body, all the way from the like the xiphoid process all the way down, and this line would be the linea alba, and this would be formed by the aponeurosis, or when the tendon of multiple muscle fibers in the abdomen, so the external oblique, internal oblique, and the transverse abdominis, they all come together and they form this like thick structure, and this would be the linea alba right in the middle of the body. Okay, then you would have just beside the linea alba a pair of muscles running all the way down, and these muscles would be the rectus abdominis. And finally, you'd also have the linea semilunaris, which are also similarly like the linea alba, formed by the aponeurosis of transverse abdominis muscle and whatnot. And they all form these lines right here, the linea semilunaris, and also the arcuate line. So what's the arcuate line? It's basically, if you look at the body, if somebody took a coronal section and cut me separated anterior posterior, and you see this would be my face, this is my back, he separated them, moved my back, and look from here, you'd see this arcuate line, which we'll speak about. It's essentially the end or what separates the rectus sheath, could say. So a point that happens when the transverse abdominis muscles start going anteriorly. We'll speak about it, but just know that it's there or here yani, for now. Okay. Again, here is another image. I got this actually from your slides. So again, you'd have the linea alba, the rectus abdominis on the lateral side, and then the linea semilunaris, of course, the umbilicus, and finally the arcuate line. Okay, so now they also divided the abdomen. There are two divisions, essentially, they did into a simpler one where they used only two lines. You can see the vertical and the median line. So a vertical line, a line going from all the way medially here on the median plate and going all the way down. And then the median plane is a line going horizontally. So you're kind of dividing it into 4 areas. And so this would be the upper right, upper left, lower right, and lower left. And so essentially, if a patient presents with any pain on the right upper quadrant, the thing you must think about would be an injury or a damage in the liver or the gallbladder. Similarly, if there's pain in the left upper quadrant, you'd think of the stomach and spleen. can see here the spleen right here. And in the right lower quadrant, mainly appendix or cecum. And finally, the left lower quadrant, the descending colon and sigmoid colon. It's just a division such that it's a lot easier to diagnose the case. Okay. Now, the other way is through this method where they use 3 lines and now they divide it into 9 squares, such that it's more specific on what structure is actually damaged. So the first line you can see here, this bone right here, this is the clavicle. And midpoint of the clavicle, we drew a line running vertically all the way down on both sides. So this would be the mid-clavicular line, since it's in the midpoint of the clavicle, mid-clavicular. And they also drew 2 horizontal lines, one at the subcostal plane. And so subcostal plane would be, the 12th rib. Just below it, there's a subcostal nerve, and they will draw a subcostal line there running horizontally. Similarly, the intertubercular plane, and essentially you'll end up with this image right here. And as we said, they divided it into 9 regions. And so these 9 regions are also important because they're reported especially for referred pain, which we'll speak about in a second. So for now, you could see 1 is the right hypochondrium, 2 would be the left hypochondrium, and 3 is in the middle. That's the epigastric region. Also with 4, that's the right lumbar, 5, left lumbar, and 6 is the umbilicus. So if there is skin over here, you'd find an umbilicus lying somewhere here. And then 7, you'd have right iliac, 8, you'd have left iliac, and finally 9 is the hypogastric. As you can see, I shaded on these 3, the epigastric, the umbilical, and the hypogastric, because, as we said, it's important for referred pain. So if a patient presents with pain in the epigastric region, then you think that there's a problem with foregut-derived structure. I'm pretty sure you guys took this in embryo, but really quickly, foregut-derived structures would be like the lower esophagus, the stomach, and the upper part of the first part of the duodenum. So that's the foregut-derived structures. And so if you have any damage to any of these structures, referred pain would be to the epigastric region. Similarly, the umbilical region, if you have any pain in midgut-derived structures, these would be, again, what are midgut-derived structures? These are like the rest of the small intestine and until the 2/3 of the transverse colon. So small intestine, the duodenum, the jejunum, the ileum, the cecum, the ascending colon, and 2/3 of the transverse colon. They would all get referred to this umbilical region, and also the appendix. That's why if a patient presents with appendicitis, you'd have pain in the umbilicus. So that's why, even though you might say like the appendix is, you can see it's not even, it could be considered in the umbilical region. It's like a mix between the umbilical, the hypogastric, and the right iliac region. However, the referred pain would always go to the umbilical region. Finally, if you have pain in the hindgut-derived structures, so the rest of the descending, so the 1/3 of the descending, the transverse colon, the descending colon, and then the sigmoid colon, all these structures would give referred pain to this hypogastric region right here. And so this is basically what I just said. So foregut-derived structures is referred to the epigastric region, midgut-derived structures would be to the umbilical region, and the hindgut-derived structures would go to the hypogastric region. Okay, so now, this image is not well put, but we'll explain it really quickly. So now, at the thoracic area, for example, you have a lot of protection of the lungs and the heart through the muscles and also through the ribs. So you have a thoracic cage covering. However, in the abdomen, there's not much protection there. And so this protection is brought about by a lot of layers just above the abdomen. So if we're going from most superficial to most deep, you're going to start with the skin, and then you'd have the superficial fascia. And the superficial fascia, you'd have 2 parts of it. Superficial fascia, a fatty layer of superficial fascia, which is the most, just below the skin, and then a membranous part of the superficial fascia. And then under the superficial fascia, you'd have the deep fascia. It should be written here, but this diagram again is missing a deep fascia. But you'd have a deep fascia under, since you have superficial, of course you'd have deep. So you'd have two parts of the superficial, a fatty and membranous layer, or campered and scarped fascias, and then the deep layer. So three layers just behind each other. And you might ask, what's the function of a membranous layer? Really quickly, it just soothes the movement, so prevents its friction, so it allows things moving like frictionless. And so, yeah, that's basically the function. So that's the way you could remember it. There is always a fatty layer, a membranous layer, and then the deep layer. Then below the deep layer, you'd have the three muscles, the external oblique, the internal oblique, and the transverse abdominis muscle. And then below the transverse abdominis, you'd have the transversalis fascia, which we'll speak about also a lot in the end. And below the transversalis fascia, you'll have the extraperitoneal fat, and then the peritoneum itself covering the abdominal structures. So that's like 10 layers, and I think 10 layers of structures surrounding or above protecting the abdomen. Okay. Now we're done with one part. Now the second part would be the vascular supply and innervation. Okay, so before we go into the details, let's just think of where they are found. So all nerves and deep blood vessels all lie in the neurovascular plate. So you might ask, where is the neurovascular plate? So the neurovascular plate, you see here the internal oblique muscle and the transverse abdominis muscle, right? So here are this area right here. There's a space in between both these muscles, and this space allows the passage of the blood vessel. And this space is also called the neurovascular plate. So it's between the internal oblique and between the transverse abdomen. Or yeah, transverse muscles or transverse muscles. Okay. Moving on now to the innervation. So we said that the abdomen generally starts from the diaphragm or the lower thoracic cage all the way down to the pelvic end. So a good way to remember it would be that the diaphragm, it could start from the lower thoracic cage, which is at T7, and then or at the xiphoid process, and all the way down to L1. So where is C7? This rib right here, that's C7. You'd have T8, you'd have T9, and T10. These are intercostal. So the intercostal nerves, so nerves going below the vertebrae or the ribs. And so it's 7, 8, 9, and 10. And you can see at the back 11, and here it's 12. But 12, it's not an intercourse. It's a subcourse because it's below, there's nothing below 12. So it's subcourse. And finally, you'd have here, this one right here, that's L1. L1 is going to give out two nerves, not one, two. So it's going to give out the iliohypogastric nerve and the ilioinguinal nerve. So essentially, you might think they are 8 nerves, and this is partially true. There are 8 nerves coming from 7 spinal segments. So from T7 to L1, that's 7 spinal segments, and 8 nerves. Okay, that's basically the innervation. Also with the arterial supply, as we said, you have deep and superficial. The deep are the ones running in the neurovascular plate. So yeah, we said that the deep blood vessels lie in the the only deep. The superficial one lies more superficially towards the skin. So now for the memorization of these parts. Unfortunately, I couldn't get any mnemonic for those, but you'll have to deal with it, honestly. I'm sorry. But superficial arterial supply, you'd have superficial epigastric. From its name, you could guess it's superficial because superficial epigastric. And then you'd also have superficial circumference. You know what? You could actually memorize the superficial. You have two superficial. One superficial epigastric, one superficial circumflex. Now the deep. The deep, you'd have the lumbar artery. You could say that, yes, the abdomen is in the lumbar region. That's why you'd have lumbar arteries. That's a good way you could memorize it. And then you'd have posterior intercostal. Similarly, you had intercostal nerves. You'd have intercostal arteries, but the posterior intercostal, not the anterior, posterior. And finally, the superior and inferior epigastrics. So once you have a superior, you'll always have an inferior, so superior epigastric and inferior epigastric. So essentially, you have 3 epigastrics: superficial epigastric and deep epigastric. The deep epigastrics, you have 2 types: the superficial or 2 vessels, the superficial epigastric and the inferior epigastric. Okay. Again, the venous drainage, there's not much I could help you with in memorizing them. But for the deep veins, thank God they follow the arteries. So the veins would follow the arteries, the deep veins. So if you have a lumbar artery, you'd have a lumbar vein. If you have a posterior intercostal artery, you'd have a posterior intercostal vein, superior epigastric, inferior epigastric. You get the idea. Now, the superficial ones, it's not that look, the superficial ones, you have the axillary vein and the femoral vein. These veins are, you're going to learn more about them in MSK block. So don't worry about them now. However, you should remember these, the lateral thoracic vein and the superficial epigastric vein. So you could see the superficial epigastric returned back again as a vein, but the lateral thoracic is a completely new vein. Now, how are they divided? So any structure above the umbilicus, it would drain into the lateral thoracic vein, and then the lateral thoracic vein would go all the way up to the axillary vein. Where's the axillary vein? It's in the region like in the armpit region. So it goes all the way up to the armpit region and drains there. Now, any structure below the umbilicus would drain into the femoral, into the superficial epigastric, and the superficial epigastric would then go to the femoral vein. So the femoral vein, again, it's at the hip. Not at the hip, it's in the medial aspect of the thigh. But any superficial, any structure below the umbilicus would drain into the superficial epigastric and into the femoral vein. Okay, so now moving on. The lymphatic drainage. So similarly, like the veins, you'd have anything above the umbilicus would drain into the anterior axillary lymph node. And remember when I said axillary, it's somewhere in the armpit region. So it all goes there. And then anything below the umbilicus, not like the veins would drain into the femoral vein. However, in the umbilicus and the lymphatic drainage, they would drain into the superficial inguinal lymph node. So we'd have this, okay, you'd have this ligament, we'll speak about it, but really quickly, this ligament attaches the anterior superior iliac spine to the pubic symphysis, and you see these three lymph nodes right here. These are the superficial inguinal lymph nodes, and they drain everything below the umbilical. Okay, so now we could say like we're done with the dry part of the lecture, inshallah. So now we could actually get into the more interesting stuff. So now the arrangement of anterior abdominal wall structures. First of all, we'll speak about the rectus sheath. So what's the rectus sheath? Remember when I told you that all the muscles of the anterior abdominal wall, so the external oblique, internal oblique, and the transverse abdominis, they all come together in the midline and they meet, form an aponeurosis, and this would be the linea alba, right? And so they're not randomly ordered. They have a certain order to them. And this all depends on their location. So they could be, remember the arcuate line, you'd have different aspects above and below the arcuate line. Because as we said, above the arcuate line, the transverse facialis muscle or transverse abdominis muscle did not go anteriorly yet. However, below the arcuate line, it does. But you see differences when you look at it from inside. So now, what happened? The external oblique, you can see the muscle fibers or the tendons of the external oblique extending anteriorly and they meet here. And then also the internal oblique, they divide into two parts. Part of it, half of the muscles go anteriorly and half of the muscles go posterior, surrounding the rectus abdominis. So the external oblique surrounds the rectus abdominis with the internal oblique, half of the internal oblique. And at the back, you'd find half of the internal oblique and the transverse abdominis also come at the back. So this area is above the arcuate line. Now below the arcuate line, you'd have a different order. So now the transverse abdominis muscle goes anteriorly, or you could also say that the rectus abdominis muscle goes back. So the transverse abdominis goes in front, or the rectus goes back. So once the transverse abdominis goes front, you can see the internal oblique is also at the front, the transverse abdominis is at the front, all these muscles are at the front, and they form the similar aponeurosis, the linea alba. And at the back, it's not, there's no muscles anymore. And so this would be the order of the rectus sheath below, or at the level below the arcuate line. So again, this is just a repetition, but in words. So above the arcuate line, you'd have 1.5 anteriorly. What do I mean by 1.5? So one muscle, which is the external oblique completely, and half of the internal oblique would go anterior. And also, and also 1.5 posteriorly. So the other half of the internal oblique and the transverse abdominis. Now, below the arcuate line, you'd have 3 anteriorly. So all 3 muscles would go anteriorly: the external oblique, the internal oblique, and transverse abdominis, and nothing posteriorly. So 0 muscles posteriorly. I wrote transverse fascia, but that's always posteriorly anyway. Okay, I hope this is clear. Now, inguinal canal. So what's the inguinal canal? When I say inguinal canal, this is a pretty difficult concept. But I remember staying late night last year just trying to understand the inguinal canal, and I couldn't understand it. Hopefully I'll try to simplify it to you guys right now. So essentially, when I tell you inguinal canal, it is a defect. So normally it's a defect in the posterior abdominal wall. So you have the abdominal wall anteriorly and posteriorly, and the posterior abdominal wall is a defect there. What happened is that there is an opening on the transverse facialis or the transverse fascia, transversalis fascia. So both are the same, they're interchangeable. You have this opening, and this opening continues anteriorly all the way to the external oblique aponeurosis. So it continues, so it's forming like a canal all the way anteriorly through, starting from the transversalis fascia and the external oblique. And I remember, last year I was like, what's the function of this inguinal canal? Why is it there? What's its importance and anything? The inguinal canal is important when there's development of the gonad. So the testes in males and ovaries in females. Why is that important? Especially for males, because in males, the testes, they develop at the posterior, at the back of the body. So this is the front of the body, this is at the back. So the testes would develop at the back of the body. However, when the baby is born, the testes should descend. They should be in the scrotum for males. And so this inguinal canal is important for that reason. This inguinal canal allows the passage of the testes from the posterior wall all the way anteriorly and drops it into the scrotum. And you'll speak a lot more about this in the endorepro block, inshallah. But this is the whole concept of the inguinal canal and why it's important. So it's a posterior abdominal wall defect that allows the gonad and testes in males, ovaries in females to descend, especially if testes to descend into the scrotum. So it's an opening, but it never closes. That's why it could cause certain problems such as hernias and whatever. We'll speak about. Now, as we said, the inguinal rings or the inguinal canal, you'd have 2 openings. The first opening is the deep opening at the level of the transversalis fascia, not the transverse abdominis muscle, the transversalis fascia. And so this opening is the deep opening, as it will continue anteriorly to the external oblique aponeurosis. So it will continue until it would start from here, for example, and it will continue anteriorly to the external oblique aponeurosis. Now, the borders of the inguinal canal, again, you could try to think about it and imagine it yourself. So you have a canal. What would be the most posterior structure? If it already starts at the transversalis fascia, you'd say that posteriorly you'd have the transversalis fascia. So the opening is at the transversalis fascia, but the canal itself is beyond the transversalis fascia. And so the most posterior structure would be the transversalis fascia itself. And now if you also say anteriorly, so the most anterior structure, so if you have the canal, you can see, let's look at this image. So you could have the canal right here, the most anterior structure, you'd have the external oblique muscle. Also, besides the internal oblique, probably, I'm not really sure why, but it's also found anteriorly. You cannot deny that, but both of them are found anteriorly. Now, also you'd have inferiorly, remember the inguinal ligament that I said, it extends, it's like, it looks like this. I'd always imagine it like this, and it extends from, wait, I have a picture, yes. So it extends, you can see here the anterior superior iliac spine, and it extends all the way to the pubic symphysis. And as we said, the inguinal canal would be somewhere around here. And so essentially, what's found below the inguinal canal, it would be this inguinal ligament. And finally, the superiorly, what would be found above the inguinal canal, that would be the internal oblique muscle fibers, the transverse abdominis muscle fibers, the actual muscle fibers going above. Okay, I hope that makes sense. This is the inguinal ligament again. And now to the interesting, really interesting part. So if you remember when I said if a person cuts me in half, takes the coronal section, so this is my body, for example, and he cuts, this is the anterior part, this is the posterior part, and he separates both, he cuts it like this. So now he has only the anterior part, and now this is my face, this is my back, he cut it, right? But now he's looking like this at the back, right? So when he looks at the back, he's going to see this image right here, what you can see. So first of all, first thing that you can see is this median. It's going median. It's a median. It's going in the median side of the body, and this structure would be the obliterated uricus. It's the median umbilical ligament, which is also called the obliterated uricus. I'm sure you guys took this in embryo with Dr. Paul. So really quick revision, an obliterated uricus. What's the uricus? A uricus is a connection between the urinary bladder. See, this is the urinary bladder, connection to the umbilicus. And so if it does not get obliterated, it does not close, you could have uricuses or whatever. But yeah, so this would be the remnant of the uricus. It's called the median umbilical ligament. Now, just lateral to the median umbilical ligament, you'd have another structure, which would be the medial umbilical ligament. So median, which is at the center of the body, then medial umbilical ligament, also, which is an obliterated umbilical artery. It's the remnant of the obliterated umbilical artery, which is important during embryological development. Now, the final thing, laterally to the medial umbilical ligament, you'd have lateral umbilical ligament. So the lateral umbilical ligament should have the inferior epigastric artery and vein. Remember when we spoke about the deep and superficial arteries and veins, and we said that the deep arteries, you'd have the lumbar artery, the posterior intercostal, the superficial or the superior and inferior epigastric artery. And we also said that the veins would follow the arteries. And so you'd have inferior epigastric artery and vein all running through this lateral umbilical ligament. Now, these are like structures, but now we need to correlate them with something, right? So what's the function? These areas right here, I don't care about. Forget about them. The area between the median umbilical ligament and the medial umbilical ligament. Forget about them. There is not found. Okay, the important stuff is in this area right here. So the area between the lateral umbilical ligament and the medial umbilical ligament, and the area lateral to the lateral umbilical. So this area, region right here. So starting off, this region, you'd have the deep inguinal ring. Remember the deep inguinal ring, the opening in the transversalis fascia. And so this deep inguinal ring would start at the lateral side of the umbilical ligament and is going to continue to the superficial inguinal ring, which is found in this region right here, the between the medial, so this is like medial umbilical ligament and the lateral umbilical ligament, it would be found somewhere here. Hope you got this. Okay, now also Hasselbach's triangle. Hasselbach's triangle is used in surgeries to to find where the canals are and the hernias are and whatever. So it's like a waypoint. So how do they draw it? So first of all, you have this line right here, which represents the rectus abdominis. So medially, you'd have rectus abdominis. And then laterally, you can see these vessels. We just spoke about them, which would be the lateral. You'd have the inferior epigastric vessel laterally, right? And now finally, you'd have something running below. And we also spoke about this a lot, which would be the inguinal ligament. Remember the inguinal ligament from the anterior superior iliac spine all the way down to the pubic symphysis, right? So that's the how Hasselbach triangle is made. Now, again, here is another visual representation of Hasselbach triangle. You could see from below anterior superior iliac spine to this would be the inguinal ligament, and then these are the epigastric artery and vein, inferior epigastric, and then you'd have the rectus abdominis. Perfect. Perfect. Now, finally, to the clinical conditions, the last part of the lecture. So, the clinical condition we'll be speaking about much would be the abdominal hernia. So, what's the hernia? Generally, what's a hernia? Any hernia would be a protrusion of a part of a body. So, an abdominal hernia would be a protrusion of part of the abdomen. So, where would it protrude? To anywhere beyond its normal borders. So, the abdomen, we said it's from the xiphoid process, you can see from the diaphragm, from the lower thoracic cage all the way down to the pelvic inlet, right? So that's where the abdomen swung. Any protrusion out of these borders, it's called an abdominal hernia. Now, another thing I need you guys to look at would be that the first structure, which is crossed by any abdominal hernia, would be the transversalis fascia. Any abdominal hernia would have the transversalis fascia being crossed over. And we spoke about the transversalis fascia. It harbors the deep inguinal ring, and so on and so forth. Okay, now that's the composition of abdominal hernia first. Now, the composition of the abdominal hernia, we have three structures or three things we need to speak about. First of all, the hernial content, and from its name. So, what is the hernia essentially? What is the protrusion of? What abdominal part did protruded? So, in this case, you could see these are loops of ileum, and so this would be the hernial content. The hernial sac would be, you see this, when they protrude, they pick up some or like stretch some more peritoneum with them. And so this, you could see that the loops of ileum would take the peritoneum with them. And so this peritoneum is the hernial sac. So altogether, they are the hernial sac. And finally, you'd have the hernial covering. Oh, before the hernial covering, the hernial sac, once it protrudes, you have two parts of it. So the neck and the body of the hernial sac. So the neck of the hernial sac, you could see it's the region that is compressed, you could say, and it's the narrow part. And the head or the body would be essentially the hernia itself. Finally, the hernial coverings. So the hernial covering, again, when the hernia starts forming and it pushes the peritoneum, remember the 10 layers, it also starts pushing the 10 layers of the body. So it's the skin, the scarpa, the compressed fascia, the deep fascia, whatever. These structures also get pulled with the hernia itself. So the hernia takes the peritoneum, takes these layers, and see, it pulls on the anterior abdominal wall, and it forms this layer around the peritoneum. And so these are the hernial cover. Okay. Now, to the common types of hernias, finally. So we have 5 common types of hernias. However, one of them is divided into 2 parts, which is the inguinal hernia. So you have inguinal hernia, it has direct and indirect. You have femoral hernia, you'd have umbilical hernia, you'd have epigastric and spigelian hernia. Now, starting with the indirect hernia. So the indirect hernia, first of all, you'll have to remember which one is the most common, which one is most common in males, which one is most common in females, the presentation, typical presentation. So you guys have to know this, and I'll try to make sense of why on most of these. So it is the most common form, the indirect inguinal hernia. It is the most common form of hernias, of abdominal hernia. It is more common in male than in female. So also, you'll have to know this. It's more common in males than females, and finally, it's also more common on the right side of the body. So most common form, more common in males than females. I almost made a mistake there, and more common on the right side of the body. Now, what's the pathway of the hernia itself? So remember, this is the inferior epigastric vessels, and we said it's the lateral umbilical ligament, and so lateral to that you'd find the deep inguinal ring, and so the abdominal hernia would happen through intestines or loops of intestine, usually loops of intestine, entering through the deep inguinal ligament or deep inguinal ring, all the way through the inguinal canal, and specifically in males, they would drop into the scrotum. So, so the indirect, essentially, deep superficial scrotum. So indirect. Now, the direct inguinal hernia, no, it skips. So it's not, you see the inferior epigastric vessels, again, they're rising like this. And so medially, it would be found medial to the inferior epigastric vessels where the superficial inguinal ring is found. So it's going to skip and it's going to push through the superficial inguinal ring. As we said, it's a posterior abdominal wall defect already, but any protrusion through it would cause a hernia. And the direct inguinal hernia usually happens to old men. It's a disease of old men. So essentially, inguinal hernia, you'd have to associate it with men. Usually men get the inguinal hernias. And for direct inguinal hernia, it happens for old men because they usually have weak posterior abdominal wall. So the posterior abdominal wall are weak, and so any protrusion would happen, and it would push through the superficial inguinal ring. And it never descends to the scrotum, and you could just imagine that because it never entered through the deep inguinal ring. So it never entered the canal itself. So it would never be able to descend to the scrotum, right? However, with this one, it took the whole pathway. It started from the deep, it continued. It's just like the testis took. So the testis would enter through the deep, exit through the superficial, and descend to the scrotum. So the indirect would descend to the scrotum. However, the direct, it never enters the deep. It just goes through the superficial, and so this would cause it not to descend in the scrotum. Again, here's a visual representation of it. I took it from the slides as well. And if you find a clinical case that says there is a hernia in the scrotum, so you'd have to think about indirect. If it's a hernia that did not descend the scrotum, طبعا هيكون direct. If it presents with an old male at the it's like the first two sentences or the first two words of the case itself. An old male presented to the clinic with a hernia. Direct. You'll have to think of that. Don't put it directly. Because sometimes it could change you. It could play with the question itself. But you'll have to think of direct. Keep that in mind. No? Okay. Now, femoral hernia. So now let's forget about the inguinal canal for a bit. Alas, we have no use for it now. The femoral hernia is completely different. Why? Because the femoral hernia enters through two paths, through two holes, you could say. Similarly, like inguinal hernia, the indirect one enters through the deep and superficial. This one enters through the femoral canal or femoral ring. Again, you'll learn more about it in the MSK. It contains a lot of the blood vessels and nerve supply for the lower limbs in general. And so the intestine, the loops of intestine would usually protrude to the femoral ring and go all the way down and exit through this opening right here, which is called the saphenous opening. So it would look something like this. The loops of intestine would enter through the femoral ring, exit through the saphenous opening. Now, it's the most common type of hernia, especially in females. So it happens in females. And you might ask why. It's usually because females usually have wider hips. And so this opening would be stretched out wider, and it allows also for passage of the loops of intestine into that hole. Okay. Now here's a quick difference between the inguinal hernia and the femoral hernia. So the inguinal, you can see this is the inguinal ligament. We spoke a lot about it today, right? So any hernia that occurs, that happens or starts above the inguinal ligament, that's an inguinal hernia. Anything below the femoral, below the inguinal ligament is the femoral hernia. You might ask, the scrotum, when the hernia drops to the scrotum, it's below the inguinal ligament. Shouldn't that be an femoral hernia or whatever? No, because the pathway, the hernia started forming above the inguinal. So it entered first the deep, and then it exited from the superficial, and then it dropped. However, with the femoral hernia, no, the femoral ring or canal is below the inguinal ligament, and so the hernia did not start above the inguinal ligament. It began below. Hope that made sense, yeah. Okay, now to the umbilical hernia. So again, the umbilical hernia, they kind of separated them into two types. So congenital, or when they are born with it, or acquired, when an adult presents with it. So a congenital one is the actual umbilical hernia. Why? Because there is actual protrusion of loops of intestine through the umbilicus itself. So that's why it's called umbilical hernia. It's due to a scar of the umbilicus. You'd have the scar of the umbilicus once you cut off the umbilical cord from the newly born fetus. You'd have a scar formation of the umbilicus, and this scar might be weak at the first couple of days, especially, and so this would lead to a protrusion of the loops of intestine out of this scar. However, there is no need for treatment for it. It usually goes by itself. And so yeah, that's the congenital. The babies are usually born. Now the acquired is not actually called the umbilical hernia. It's called the para-umbilical hernia, because the loops of intestine do not really exit through the umbilicus itself. It exits through the linea alba. So you remember the linea alba in the middle, it would exit through these surrounding, it's an area surrounding the linea alba surrounding the umbilicus. So not the linea alba at the top or at the bottom, the linea alba at the region surrounding the umbilicus. And it usually, as we said, occurs in adults. That's why it's called acquired, not congenital. Okay. The epigastric hernia. So for the epigastric hernia, you'd have, if you remember the epigastric region that we explained, so it's essentially a region between the xiphoid process, or at like the lower border of the sternum, the lowermost part of the sternum, and it continues all the way to the umbilicus. That whole region right there would be the epigastric region. So a hernia in that region, usually also again at the linea alba, would be characterized as an epigastric hernia. As I brought this image to try to help you imagine it. That's, yeah, so this would be the xiphoid process. You could go all the way down to the epigastric. Any hernia in this region right here would be an epigastric hernia. However, if a hernia like happens in this region right here, this is a para-umbilical hernia because it happens at the linea alba, but at the umbilical level or below it, just below it. So that would be an para-umbilical. That's from the xiphoid process to the umbilicus, that would be an epigastric hernia. Okay. Now to the Spigelian hernia and our final hernia for today. The Spigelian hernia, we said that an umbilical hernia at the linea alba, you'd have a para-umbilical hernia, and a hernia at the region, at the linea alba between the xiphoid process and the umbilicus, any area between there would be an epigastric hernia. Now, the Spigelian hernia is a hernia on the linea semilunaris. And how is the linea semilunaris called? We said it's due to the tendon or, so the fascia of the transverse abdominis muscle. Not the fascia, so the ligaments of the transverse abdominis. They form aponeurosis there. And they form this linea semilunaris, these areas right here. So a hernia in these areas would be characterized as Spigelian hernia. Again, it's an uncommon hernia, occurs through aponeurosis of a transverse abdominis. We already said the aponeurosis of the transverse abdominis would, so you see this visual representation, rectus abdominis, transverse abdominis, and the protrusion is in the linea semilunaris. It's just below the umbilicus. And a characteristic thing is the neck of the sac is narrow. So remember when we spoke about the umbilical, the hernial sac, we said we'd have a body. So this would be the body of the hernia, contains the peritoneum, and the neck of the hernia. So the neck is usually narrow and strangulating, and this is a problem with all hernias, not only Spigelian, but it's more specific and more characteristic of Spigelian because it's usually, the Spigelian hernia usually present with strangulation of these muscles. So you'd have blood vessels and nerves going also through these neck, and this strangulation causes blockage of these arteries and blood vessels, which could cause death of that part of the body and ischemia, and we do not want that. This is, again, this is a problem for all hernias, but it's a characteristic of Spigelian hernia itself. So sometimes you might present, might have an adult who has an umbilical hernia, but there is no strangulation. فخلاص, you leave him be. It's not that serious compared to other problems. Now, this is the end. I wanted to put questions, but unfortunately, as I said, this is a recorded lecture. But hope you guys enjoyed. If you have any questions, please feel free to ask me. And thank you. And this is a feedback. Please fill it. We need your responses. And hope I made that better. And thank you for your time.